Hello, everybody, and welcome to the Healthtech Pigeon podcast, dissecting and discussing the latest health tech news so you don't have to. I'm Amy, and with me today, I've got Huw and Adama from SomX. Thank you guys for joining. And very excitingly, we have Christa Natoli, Executive Director of CTel, with us today. So massively warm welcome, Christa. Welcome to the podcast. Great to have you on.
Thank you, Amy. So nice to be here with you all.
So why don't we kick off you talking a little bit about your journey, yourself, and what you do at CTel, and then we'll get stuck into the health stories.
Absolutely. So my name is Christa Natoli. I live in Washington, D.C., and I'm the Executive Director of CTel. CTel stands for the Center for Telehealth and eHealth Law, and we are a nonprofit research institute that focuses on all laws and regulations that impact the delivery of virtual care.
Amazing. And are you working on any kind of key projects at the moment that you want to talk about?
We're working on so many really cool projects. The first project that I think is probably most interesting is we're looking at the relationship between cost of telehealth services and the impact on the federal budget. And that will ultimately have an impact on the extension and permanency of the PHE waivers. We just finished a research project looking at DEA and diversion relationships through the prescribing of controlled substances via telehealth. And the third project that is probably most exciting and interesting is we are working on a data scarcity project. So most people that are in underserved communities that are high utilizers of emergency rooms often go to emergency rooms because they can't use cell phones because they don't have enough data to contact their providers or their doctors. So they use the emergency room as their primary care. We found that if you just give people enough data in these communities, that you actually decrease unnecessary utilization of emergency rooms. So that's a pretty cool project we're working on now too.
That's great. That's a quite nice one to talk about, because I think everyone can understand going to the emergency room, and it's quite a nice use case scenario of probably some of the quite complex policy topics that you work on. So, well, without further ado, then we should kick off with the first story. We're really excited to hear your thoughts and discuss in a little bit more detail around some of the US policy and hear from your side what's been going on over there. This story is focused around a report on patient attitudes towards AI. We've seen a few of these reports coming out in the last few years. So this one was quite a nice, interesting addition to that. And here in the story, we've seen that they're shedding light on both the type of trust that people have, which is in this case listed as responsibility, healthcare providers' responsibility to use AI, and also the harms that might be caused from that. So there's sort of different types of trust that were analysed, and also different types of groups that were analysed as well. So the results of this study show that most of the respondents reported low trust in their health system's ability to use AI responsibly and ensure that AI won't harm them, which is obviously not great. So, we don't like to hear that people don't have trust. It's something that we talk quite a bit about on the podcast, and I'm looking forward to hearing your thoughts on it, especially from a regulation standpoint. From your side, it would be really interesting to hear, does the attitudes that were reviewed and the results that came out of this survey, does that align with what you might have predicted based on, work that you're doing? I mean, you're obviously very close to this area. And why do you think that, in a broad sense anyway, why do patients need to trust AI?
Yeah, these are great questions. First, I want to begin with saying I don't know their methodology. So I don't know how the questions were asked. But I think we have to divide this into the reality of how AI is being used and the myth of what people think AI is doing in healthcare. So the reality is that AI has been used in healthcare for almost 2 decades now. And it's being used in your electronic medical records. It's being used if you are engaging in any type of remote patient monitoring. So think wearable devices that like track your heart rate. There's a lot of data that comes in when you are managing an individual's like chronic condition. You have to look at their heart rate or their sugar levels over a period of time. That's too much data for one provider to look at or even one care team to look at. So there's algorithms that are put in place to get rid of all of the white noise and to segregate the data that is most important, that are outliers that that doctor or clinical team will need to pay attention to. That's been going on for a really, really long time, and that is AI. So when you look at how AI has been used, it's been quite helpful. Now, there's this idea by a lot of people based on stories and social media that AI is going to take over healthcare. We're going to have doctorless hospitals, and AI is essentially going to have robots at bedside, and that's not true. There's already laws and regulations that create a structure on how digital health is to be used in a patient encounter. And those laws and regulations have almost 100 years of precedent. So regardless of the technology is always going to change and it's going to advance. But the laws and regulations say at a state level, even at a federal level, it applies to reimbursement. If you are to engage with a provider, that provider has to meet certain thresholds. And one of those is they have to do a proper examination, and they have to be the ones that are prescribing and diagnosing. That already immediately eliminates AI from diagnosing or prescribing to the patient. So what it leaves the doctor with is AI as a tool.
I mean, you mentioned laws and regulations, which is something that we'll come on to, I'm sure, and you can explain a little bit more about that. But there's a line in that story that mentions healthcare stakeholders are increasingly taking steps to self-regulate their health AI development, including consortiums like the Trustworthy and Responsible AI Network, TRAIN. Do you have any thoughts on that? And have you seen that on your side? And how does that link? I mean, you mentioned there's laws and regulations we have at a country level. Where does the self-regulation come in, and how do they work together?
So AI is really complicated. So there's the technology piece of AI, and that's not anything that falls within CTel's scope. What CTel focuses on is once the technology is determined to be appropriate, and then it's now being applied to that healthcare encounter, how is that clinician using AI? Are they using it in an appropriate way? So, for example, a good use of AI would be if you have a chronically ill patient and you are trying to track their vitals over a period of time and use AI to take out that important data and to be able to escalate that important information to a clinical care team so that clinical care team could act almost in real time. A bad use of AI would be a model where a clinician was just there to sign off on a prescription that was being assessed by an AI algorithm. So let me give you an example. There are bad actors all the time, if it's in person or virtual. And sometimes we saw these bad actors trying to commandeer the term telehealth and say that they're using telehealth to engage in patients, when it's really nothing more than a doctor rubber stamping prescriptions. We could see AI doing the same thing, where you you put in all of your information. You know, my name is Christa Natoli. I have a really bad sore throat. I've also had a headache for a couple of days, and I put in all this information, and then the AI algorithm spits out that I have X problem, and then the doctor goes, "Yep, I'm going to write a prescription for Y." That is not a good use of AI, and that's not appropriate. It's not allowable in any of the 50 states.
How do you decide what's good and bad AI?
Well, it's not really how we decide what is good, bad AI. It's what is appropriate medical care. And there's already multi-year precedent, 100-year precedents of like what is considered appropriate. And that medical standard is not only at a national level, but then it gets even more filtered to even at a state level and a county level. So medical boards and nursing boards have jurisdiction over how you appropriately engage with a patient. And there is very clear, there's very clear lines on how you engage with that patient. So you have the very first piece is that you have to be licensed in that state. The only person that could be licensed in a state is a human being that is a clinician, and that clinician has to have gone to school. And that doesn't allow for an AI algorithm to be considered a licensed provider. So that's number one, you have to be a licensed provider. Number two is you have to conduct a physical examination of that patient. Now that physical examination can take place in person or it can take place virtually. A physical examination cannot take place by an entity like an AI algorithm. The third is that then you have to assess that patient and determine what their medical issue is. Now, you could use an AI tool to help with that assessment, but ultimately it's the provider that diagnoses. So the standards are already in place. So we don't have to be fearful that, oh, AI is now on the scene and all of a sudden we're going to have poor access to care. Of course, if it's done poorly and it's misused, yes, that is a possibility, but the laws and regulations already exist to prevent that.
I'm interested in this one because I guess there's kind of two uses of AI in their own ways. There's the kind of clinical, how are we using it in telehealth? How are we using it into that kind of application of, is the AI diagnosing? Is the AI being the sort of direct treatment piece? And then there's the other ways that AI is being used in clinical practice, particularly for generative AI, even though there are, AI has been around for so long. I'm thinking sort of the ambient scribe and the clinical scribe and the clinical co-pilot that it's definitely playing a role in that delivery of care piece. It's definitely playing a role in the provision of care, but I think a lot of people would argue that the ambient scribe listening while the doctor also listens and then you reconcile at the end. Do we still have questions from a kind of regulatory? Does that kind of feed into how patients feel about the responsible use of AI in their care? Where does that go from? Where do we go from that?
Yeah, so it's really interesting that you bring up the EMR piece. So clinicians are completely overloaded with administrative work. And so oftentimes what they'll do is, and there's been loads of studies to assess this, is that you come in and Amy comes into me and I am her doctor, and Amy is still dealing with high blood pressure. And so instead of taking all the new notes about her high blood pressure and her symptoms, I copy and paste the last time that she was here, and I copy and paste those notes directly into her chart for today, February 21st. But maybe some things have changed. And the next time Amy comes in is maybe in April. And Amy goes, no, I never said that. I mean, I had that a long time ago. When you copy and paste these previous records, there's information that gets lost. It allows for medical liability. It allows for misprescribing. And so what the EMRs right now are trying to do is they're trying to integrate AI to remove any mistakes or essentially like the copying and pasting of of previous medical records, which has created misdiagnosis of a patient. It's created overprescribing. It's essentially put a lot of patients at medical risk.
It's interesting that, this idea of trust, and I'd love to just kind of just touch on that again briefly. In this particular article, it makes sense that the people with a higher trust in the health system were more likely to believe that the system would use AI responsibly and protect them from harm. Whereas people experiencing discrimination in the system were less likely to trust that AI was being used responsibly and that it's protecting them from harm. Mm-hmm. There's a couple things to dig into. One is, people's attitudes towards responsible AI. I mean, some of the things you mentioned around the use of AI, it's the regulations are there, and we're considering the patient outcomes as there's medical boards involved. But I wonder if, from a patient perspective, if they see it in that way. I'm not convinced. If they see the use of AI in that way, it feels more like it's perhaps less integrated. Or what do you think are the main sort of barriers that people are to trusting this?
Yeah, absolutely. And any hesitation to new technology is valid. So there is a platform, there are laws and regulations in place to protect patients, but could bad actors still engage in the process? Absolutely. We see that with in-person medicine, we see that in virtual medicine as well. If there's hesitation, there needs to be hesitation with any of these direct-to-consumer companies. And sometimes those direct-to-consumer companies act alone, and you could just you could find them on a simple Google search, or sometimes they white label and they integrate within health systems. Here is where the hesitation needs to come from. There is no central AI brain. And what I mean by that is there's no central database where all of the AI information and data is being held. So there are lots of scenarios where AI could be discriminatory based on how you train the brain. Okay. So if you are looking at a patient population and it's non-representative of men, and you only look at women, or you don't look at pediatrics, then that data set is not going to be able to properly represent questions that are geared towards the populations not represented. And so that's really, really problematic. And we need to think about that. So when we are looking at AI algorithms, or a hospital is looking at AI algorithms to invest in, let's say it's a derm app. And dermatology was the very first to use AI. And it's because most of derm is pictorial. So you could take a picture of the infected area, and then you can compare it to other images. Well, if the AI is only trained on a certain skin tone, then it leaves out darker skin tones. And then therefore there's biases within that algorithm, and it may miss a cancerous lesion or something else that could potentially be very fatal to that patient, just based on the fact that the algorithm wasn't trained for it. And so there are discriminatory patterns within these algorithms.
Just thinking as you were talking there, I mean, discrimination in science has been, it's already there. So it's interesting that this obviously gets picked up in the AI stuff, which is completely understandable based on what you just said. It makes complete sense that people would be worried about it. But we know that a lot of scientific studies have failed to address vulnerable populations as well. So yeah, it's maybe it's a flaw in the wider system of medicine and science rather than just AI. I don't know.
Well, yes. I mean, medicine has inherent biases for a very long and unfortunate period of time. But what we're looking at here is, I think the question is, are there mechanisms legally already in place to protect patients? Yes. But that is to protect the patient, to make sure that the patient is not being prescribed based solely on an AI algorithm, meaning that the doctor is just not rubber stamping it. But here, that protects patients. That protects all patients. Here is where patients in the community need to be more interested in the AI algorithms that are being used, and how are they being trained, and what data are they being trained on? Because that's not necessarily something a patient would know if your doctor is using this as a tool in oncology and that algorithm wasn't trained on darker skin tones to look to see if that lesion could potentially be cancerous or not. That is an inherent bias within the algorithm. Even if the doctor is making the clinical decision themselves and they're just using it as a tool, the tool could be biased and could be negatively impacting the care. So we just need to be very cognizant about that. Not all AI is created equal, and not all AI platforms are going to provide care in the same way. Just like all medical care is not the same.
So I guess then you could argue, if you went first principles, that's a good enough reason not to use AI and to sort of put off the adoption and kind of wider rollout of it. But I guess for me, the question is it about post-market surveillance? Is it about kind of checking and ensuring that confirmation bias doesn't come into this, and so you're not listening to the AI over your essential knowledge that this may not be trained on as wide a group as possible, and we need to keep kind of learning and keep adopting and keep improving these systems? Or is it a full stop? People have a right to believe that this AI tool that's being used, there shouldn't be, or even is it sort of informing patients and that patient education piece that this tool is out there, it's being used, but don't let your clinician listen to it above what you think is wrong or what you think could be a problem.
Yeah, so there are laws that are already addressing this. So 18 states have what is called an informed consent law. And it says that if AI is being used in any capacity in your healthcare encounter, you as a patient have to sign off on it. You have to consent to it before you are treated as a patient used when your doctor uses AI. So that's a step that's already being taken to make sure that patients have an understanding. Oh, okay, you're using AI. And then number two, we also have legal precedents looking at second opinion. I think this is most similar to second opinion consults. So if you're familiar with the idea of second opinion consults, they were created many, many years ago when doctors needed the privilege to be able to contact a colleague, usually in another state, to say, hey, we're both oncologists. I have this really clinically ill patient, but I've never seen anything like this before. And the other doctor in another state would say, oh, I'm doing research on this. It might be this. And they share information. And that prevented the doctors from both being licensed, needing to be licensed in the same state, as long as it was just the sharing of information. At any point, if the doctor in, let's say, New York was providing and taking over the clinical care of the patient in Massachusetts, then that doctor in New York would also need to be licensed in Massachusetts. When you are looking at AI should never be taking over the clinical care of the patient. What I mean by that is the doctor who is providing that oncology care to that patient or whatever medical service to that patient, they have to be educated enough to be able to push back against that AI algorithm. If they're using AI to guide the care, then that's inappropriate.
It's a big challenge, though, isn't it? Because I think confirmation bias is one of the sort of big challenges that's identified with particularly use of AI in healthcare. Is that you at what point do you start, I guess, just listening to it because it's not guiding care, but it's kind of giving you the result that you've assessed, you've reviewed, and is accurate 99 times in a row. Does that 100th? Do you become more inclined to just say yes when it comes for the 100th time?
I mean, that could happen in person without the use of AI and without the use of technology. I mean, we've seen lots of studies to address confirmation bias in the assessment of a patient's clinical condition. But more importantly, I think your question is do we stop using AI until we have regulations surrounding this area that could better protect a patient? The truth is that no matter what the innovation is, you can't put a pause button on innovation. You just have to kind of build your wings on the way up. And we're in a position where we do have a set of the healthcare system. There's already laws that are protecting patients regardless of technology that's being used. If it's a stethoscope or if it's telehealth or if it's AI, these are all tools. And there's a certain standard of how you engage with these patients. But it is, as researchers, as those interested in the area, we have to be informed and understand that these technologies are relatively rudimentary compared to what we'll see in 5 or 10 or even 15 years. It's the equivalent of a rotary phone now. And in 10 years, we'll have, the iPhone 15. We have to make sure that we push back against, we have to push back against these companies that are offering or promising too much. And we have to ask questions about the biases that could potentially be within these algorithms, because we have to protect these underserved patient populations.
I think that leads quite nicely into our second story topic area, which is around the new administration changes in the US and a bit of a focus on policy. It would be super great to hear from you, Christa, from, on the ground in DC and, experience in your work. How are you feeling about the new US policy changes, the FDA cuts, and other aspects that impact you? How are you feeling about that?
Well, I mean, a lot of this is new and it's unprecedented. So we're going to have to see how it plays out. But what CTel is focused on is really, will the public health emergency waivers that were introduced during the Trump administration in March of 2020 and were continued until December 31st of 2024, will those be extended beyond the deadline of when the continuing resolution ends on March 31st of 2025? And so we know that at the end of last year, at the end of December, the Republicans decided that they were going to pass a continuing resolution that would give us 90 days, and then they would assess and determine what to do after that. Unfortunately, we are looking that we're going to have a government shutdown on March 14th. So the government is going to shut down on March 14th. The good news is, though, that the longest government shutdown in history has only been 17 days. And so it's not likely that we will have a government shutdown past March 31st, but we're in a time where anything could happen. But we hope that we will be able to, the government shutdown they'll be able to figure out what happens pre-March March 31st, and then telehealth will be included in any type of reconciliation package. Because if it's not, then we could lose telemedicine reimbursement for public health emergency waivers. And that would be really catastrophic to a lot of these hospitals and health systems that are already essentially planning for 2026. And, patients could lose access to care.
Can you talk us through because it's obviously a really different system in the kind of the reimbursement of telehealth versus obviously how we deal with it here in the UK. Can you talk us through what the current system has enabled and what you could see losing if those decisions aren't made or if that waiver isn't extended?
Yeah, absolutely. Perhaps it's best to set the stage as to why this even happened. So back in 2001, Congress was trying to regulate the budget. And in order to do that, they needed to make sure there was not unnecessary cost spent. But at the same time, there was also a conversation about this new tool, telehealth, that's able to improve access to care to patients that were in really underserved areas. At the same time, the country was trying to fight the healthcare shortage. And if you may remember, there were all these grants and incentives that if clinicians right after medical school or nursing school went into these rural areas, that their student loans would be paid for, they would receive some type of incentive. And that worked. And then as soon as their time was up in that rural area, they'd come back to the urban area. And so we were still losing clinicians. We couldn't get enough medical specialists to stay in these underserved areas. So telehealth, which was incubated with NASA and the military, and it was a way to provide care to these extremely remote populations, was looked at as a possible solution. So we have telehealth and we're thinking, okay, how do we pay for it under Medicare? And initially it was any telehealth that's used under Medicare should be unanimously reimbursed. But before a project could be reimbursed by the federal government, the Congressional Budget Office, which is an agency that tells the government how much something is going to cost, has to assess the cost spent of this program. Well, CBO, along with everybody else in 2001, didn't really know what telehealth was. There were only 2 studies, and neither of those studies were cost studies that they looked at to assess the cost of telehealth. So they were essentially going in blind. And so they assessed telehealth 83% higher than it would actually cost the federal government. So they go back. So Congress is like, hey, how much is this going to cost CBO? And CBO's like, I don't know, but we got these 2 studies. We'll give it, we'll give it the old college try. And they end up scoring it like astronomically higher. And then Congress is deflated by this ridiculously high number. And they're like, well, we can't go back to our constituents and say grandma can't get telestroke care because it's going to cost the government way too much. That would be political suicide. So ultimately, what they do is they say, okay, we need to put self-imposed restrictions on who could access telehealth and essentially what doctors can be reimbursed for it. So they self-imposed 4 originating site barriers that we right now are trying to get rid of through new laws and regulations that we're addressing in present time. And those 4 regulations are that patient has to be located in a rural area. So I'm from a 1-stoplight town in Ohio, and that is not considered rural. So it's interesting how they assess like what zip codes are rural. So that's number 1. Number 2 is that patient cannot be in their home. They have to be in a hospital or clinic. Number 3 is that patient has to be seen by a very specific provider that's designated by CMS. So a doctor, a nurse practitioner, really nobody else when this was initially determined. And then number 4 is that there has to be like a certain level of certain types of CPT codes. And there were only like 100 initially. So there's these 4 really narrow restrictions. And they thought, okay, if we could put these 4 narrow restrictions in, we'll decrease utilization and there decrease costs by the federal government. Unfortunately, it backfired because when you decrease access to critically ill patients and those in need of care, they're going to end up with medical catastrophics and end up in the emergency room and increase cost of care to the federal budget under Medicare. So that backfired. So CTel was contacted at the tail end of the Biden administration, and we were asked by HHS and White House Domestic Policy Council, do you have any data that shows that telehealth does not unnecessarily increase costs to the federal budget? And so CTel said, no, but we could do some research. And 5.5 years later, we produced a study that actually took place in the middle of COVID. And what we found is that telehealth did not unnecessarily increase costs, and it didn't increase fraudulent spend. And so that research was the very foundation for why there was the public health emergency extensions. They were able to be extended because we gave that over to HHS and the Secretary's office. And so they use that as the foundation.
And is that an avoidance of, as you say, those emergent, like patients ending up in an emergency room because they didn't have access to that kind of care, and avoidance of kind of the provision of the costs of provision?
No, we actually looked at 1.43 million telemedical encounters in all 50 states. We looked at all payer types as well. And what we found is that telemedicine was substitutive in cost to the federal budget, not additive. So it meant that, it wasn't that if a person was seen once, they had to be seen again in person. It wasn't that. Telehealth replaced the cost of an in-person exam. We also found that it was not more fraudulent in care. So it was equivalent to in-person care. And 3, the quality of interaction was the same or exceeded in-person care if that patient had to be seen by a medical specialist. And we saw that specifically in mental and behavioral health. So that research was delivered to Secretary Alex Azar during the Trump administration, and that was used for the foundation to waive the public health emergency waivers back in 2020. And then we continued using that research as a foundation and reasoning to extend the public health emergency waivers. When we delivered that research to the CBO, they said, yeah, this is fantastic. But what you're looking at right now is you're looking at pre-COVID and COVID use of telemedicine. We need post-COVID utilization trends as well. And so CTel is working on that research as we speak, and hopefully delivering it to CBO and Congress and Domestic Policy Council before Congress makes a final decision on telemedicine.
Tight timelines, is it?
It's tighter now because we thought that we were getting a 1-year extension at the end of last year. We used our congressional context, said, yeah, it's going to be at least a 2-year extension. You have a year to produce the research. And now we might have less than 90 days. So we'll see what we could do.
And how's this? I mean, how's this looked at politically as an issue? Is it something where the research is the research? People will look at it rationally and okay, yes, this does make sense, or are there vested interests that don't necessarily want this included, and this is a challenge?
CTel's research is academic research that is peer-reviewed and not funded by any vendors or anybody with a specific policy interest. And we use a third-party research team to do it. So there's a division between CTel and the research because we have an inherent interest in the advancement of telehealth. We want to make sure this research is clearly done in the highest of standards in an academic way. So, we hope that it is well received. It was well received the first time.
Yeah.
There's always, I think there is a concern among both Democrats and Republicans that telehealth could increase fraud. There is an unsubstantiated narrative where this came from, and that's because there were an increase in durable medical equipment fraud back in 2020. And there was a story that ran, and HHS quickly corrected it to say that it wasn't telemedicine. But initially that story ran and said it was telemedicine fraud. And really all that it was that there were bad actors that were non-clinicians that got access to a Medicare beneficiary list. They used a call center in India, and that call center in India then made calls, lay people made calls to Medicare beneficiaries, baiting them into saying that they needed a knee brace or they needed certain medication. And then the doctor literally just stamped these prescriptions. So that, by definition, was not a telemedicine exam. It wasn't even a medical exam. It was just complete fraud. And that's where this narrative of telehealth could be fraudulent because it took place over an internet connection. But we know, and just based on the interaction, that does not constitute telemedicine.
Reasons to be optimistic then for March.
I'm just interested on obviously this. What other research projects have you got going on at CTel that, like, in addition, obviously, to this big topic that you said the research lasted 5.5 years? Is there anything else that you're working on that you think will make a big impact on policy?
We hope so. So CTel has been working on amending the Ryan-Haidt Act. For those not familiar, Ryan-Haidt is a law that was created after a minor was prescribed medication over the internet and overdosed. And so the child's name was Ryan-Haidt, and his parents worked with Congress to pass this legislation. There was a carve-out made for telemedicine saying that you can prescribe controlled substances using the internet if you have a telehealth encounter, but the restrictions required that patient be in a hospital or clinic and seen, and that doctor comes in virtually via telehealth to prescribe that medication to the provider. So essentially that patient goes into a hospital or a clinical office, and they might not have a psychiatrist or a mental health specialist there, and that doctor comes in. What CTel has worked on is looking at the question is, does telehealth increase diversion of controlled substances on the black market? Because if it does, then Ryan-Haidt needs to remain in place to safeguard against that. But if it doesn't, then we should continue to be able to use telemedicine as the waivers apply during COVID, which allows for a telemedicine provider to provide a controlled substance virtually to a patient in their home or wherever they're physically located to improve access to care. So we finished research in about a 3-month period. We finished it at the end of December. We're sending it to a journal to be published. I can't talk too much about it before publication because it's being submitted to a peer-reviewed journal. But what we essentially found was telehealth does not increase diversion of controlled substances, and the opposite was found. So that was really exciting. We're going to deliver that, of course, to White House, ONDCP, and DEA, because this is the research that they're looking for, and hopefully it will have some impact on how they determine where the laws and regulations go once the waivers expire on December 31st.
Wow, fascinating. Thanks so much. And just before we wrap up the conversation, thanks so much for your insights, Christa. It's been super interesting hearing from the US side, which is something that we're obviously less close to over here. But I'm interested to hear, I guess this is a broad question, but, you know, coming from a regulatory, a legal perspective at CTel, how do you feel about this balance of regulation versus innovation? Because it's something that crops up in narratives quite a lot. You know, we want to foster AI innovation in healthcare, but we need to balance that with regulations. How do you, are you either, can you be both? Can you be either? Which side are you?
Also, it applies to healthcare, and we talked about earlier, regulations already exist to protect the patients. And we need to be very careful that we don't regulate against innovation, because the innovation will move way faster, light years faster than the regulations will be made. And we've seen that with telehealth, but we need to prevent against bad actors. But it's of my personal belief that there's already regulation that exists. But, you know, CTel does have an AI Blue Ribbon Collaborative, and it is made of the top academics in the United States and internationally. And they fall in the areas of medicine, law, science, and technology. And we are publishing what is considered a standards document of, you know, the checklist of what you need to do. And a lot of that will just be reiterating what the standards already say at a state and national level that help protect patients. But it is really going to serve as an education document, because sometimes new clinicians, or even those that are new to digital health, might think that a different type of standard applies, or that they have to do less than they would if that technology is not being used. So this is really like an education document saying, don't worry, it's just a piece of technology. Do as you were educated when you were in medical school or nursing school or PA school.
Yeah, I think that's a very well-rounded answer. I like that. Not too extreme. Christa, if anyone out there is listening and they want to find out more about your work, or they want to contact you or find more about CTel, where do they go?
They go to our website. It's ctel.org, CTEL.org, and we'd be happy to engage with you. If you'd like to send us an email, it's info@ctel.org.
Amazing. Thanks so much. And thank you, Huw and Adama. And that's all today, folks. So thanks for joining us, and check out the rest of the best stories of the week on our Healthtech Pigeon and Dodo newsletters. And don't forget to like and subscribe to the podcast. Thanks, everyone. Have a great day.